managed in as a luteal phase support. Now, when we try to consider the cost of minimal versus conventional stimulation, we found this study in human reproduction, which said that although the cost was higher for conventional stimulation because of the higher dose of drugs used and
time
higher number of embryos
3 minutes.
for freezing, but when you consider when factor it with the birth rate of 30% versus 55%, conventional stimulation still becomes more economically efficient. And regarding the use of adjuvants, although Ishray says that there is no conclusive evidence, but in our study we found that when patients were given adjuvants for a period of 2 months, they give better clinical pregnancy rate. Although Ishray doesn't recommend any superiority of minimal stimulation or conventional stimulation over each other, we still believe that conventional stimulation is better because it gives the higher stimulation doses coupled with consistent use of adjuvants gives higher oocyte yield and live birth rate with modest increase in embryo quality. And most importantly, we didn't find cycle cancellations in the study. So the three cornerstones of minimal stimulation advocated being the cost, what should be the ideal dose, and in our, especially suits our population.
Thank you, Dr. Coleman. So you are using 150 dose only triple. How is it?
We are using higher doses, like based on the patient's weight, 25, 300, or 375.
But yeah, I think your talk was all on conventional versus
Conventional versus, so yeah, so wanted to prove that conventional stimulation still stands in today's practice versus minimal stimulation which is being spoken about in the literature.
one slide you have shown the dose up to 375 also.
Yes, ma'am, I conventional protocol. So I have compared it with the data which says that minimal stimulation with less than 1
in conventional you have used the higher dose.
Yes.
Gone up to 375.
So I'm advocating the use of conventional.
Yes, I understand. And was it with FSH? You had HMG or with just?
Yes, both FSH and started with FSH and then added HMG in the later.
And your adjuvants are same in both the groups, conventional and the minimal.
Yes.
Thank you, Dr. Kumar. Indira Shashi. Indira's something, Dr. Indira. Who is here to present in the, because we are not Dr. Idu. Like 4 right, okay. 2 more are.
ಪ್ಯಾನೆಲ್ ಯಾರು ನಿಮ್ಗೆ ಯಾರು ಬರ್ತಾರೆ ಹಾಂ ಮಿಲನ್ ಅವ್ರು ಚೇಂಜ್ ಆಗಬೇಕಾ ಓಕೆ ಓಕೆ ಅವರು ಪೆನಲಿಸ್ಟ್ ಬೇರೆ ಇರ್ತಾರೆ ಓಕೆ ಏನಾಗಿದೆ ಇಲ್ಲಪ್ಪ ಯಾಕಾಯ್ತಾ ಇದೇನಾ ಒಳ್ಳೆ ಆಗಿದೆಯಾ ಕಾಣಿಸ್ತಲ್ಲ ಕಣ ಏನಿದ್ದಂಗಿಲ್ಲ ಕಣ ಬ್ಲೀಡಿಂಗ್ ಅಂತ ಏನಿಲ್ಲ
I'm going to present today's topic, impact of blastocyst morphology on Floyd status and clinical outcomes in PGTA cycles. So the overview of the topic is the introduction, objective, methodology, results, discussion, limitations and conclusion. PGTA has been carried out mainly for IVF patients with aim to increase pregnancy rate and per embryo transfer and decrease the miscarriage rate. Since aneuploidy increases with age, presently the main indication for PGTA is in advanced maternal age as per recent Ishray guidelines. PGTA has been recently categorized into 3 main groups, PGTA-A, PGT-M and PGT-SR. Morphological grading is a non-invasive method of assessing embryo quality, but it has its own drawbacks. Though PGT-A and morphological grading both are used to select embryo, they are technically different from precision, invasiveness and subjective variability. Since PGT is not indicated in all cases, morphological grading is still the method of choice in selecting an embryo for transfer. Keeping in this mind, the objective of our study is single euploid frozen embryo transfer, mosaic embryos and Z biopsy cases were excluded from the study. And the Gardner grading system was the method to assess morphological grading of the blastocyst embryo. the day of the biopsy. So this is the overall PGTA procedure involved in the study. It is a normal ovulation, induction, retrieval, then ICSI culturing the egg up to blastocyst. Then mostly we have done the frozen embryo biopsy, post biopsy, tubing and cryopreservation is done. After the NGS report, the embryo is thawed and transferred after full expansion. The study design included total 187 blastocyst biopsy and it was categorized into 3 groups based on appearance included in group C. The primary outcome of the study was euploidy and aneuploidy rate between different grades of blastocyst, pregnancy rate, abortion rate and live birth rate was a secondary outcome. Chi-square ANOVA test was used to add group B. Group C 46, group C 46, it was not statistically significant. Group C had highest abortion rate, that is 21%. Though we had transferred 24 euploid blastocyst of C grade, it led to abortion. So the abortion rate was statistically significant of 0.004 when compared to group A and group B. And the live birth rate was high in group A and it was statistically significant.
That was a good presentation, Dr. Sujana. For group C embryo biopsy, how easy was it to biopsy the embryo because number of cells are so less?
Less, ma'am. One was challenging because all was frozen blastocyst, and if it was not viable, that was not considered in the study. And if the embryo post-thaw, we haven't transferred. So it is mentioned in the study that only the cases which have frozen embryo transfer were included. That was one of the limitations in the study.
So the number of embryos biopsied were 180, all 180 were not transferred.
187 biopsies which had a transfer.
All the
Yes,
transfer.
ma'am.
Okay. Thank you. We have next speaker. So thank.
Senior gynecologist in obstetrician from the city of Mysore. Madam has